So again, a very good evening to everyone. So this course is on recent advances in refractive surgery, and of course, a lot has happened. Refractive surgery is ever evolving, where something new comes up every year. Few new techniques come up every year, and there's been a lot of advancement also in the investigative modalities. So Dr. Chitra gave me this topic to speak on. So if we look at how refractive surgery investigative modalities have evolved, you will see that in the 1880s, a proper Placido disc was used, and they would look through it from the central hole and with concentric rings to see the regularity of the cornea. And then that evolved into the photokeratoscopy, where a photography technique was added to it. That was in the 1950s. And we started measuring the cornea's curvatures only in the 1960s with the keratometries of the corneal measurements. And in the 1980s and 90s, we came up with the topography systems, which is what we use today. And of course, after that, in the 90s, we got the Scheimpflug imaging, which was one step higher because it could image not only the front part of the cornea, but also the posterior corneal measurements. In the 2000s, we also started doing anti-segment OCTs. I remember when Visante was launched, and we suddenly could see OCT profiles of the cornea. It went on to evolve, and then the iTrace came up with diagnostic aberrometries of the cornea. That was in 2001. In 2010, they started doing biomechanical imaging of the cornea with the Corvus system, which came up. Recently, we started using in our clinic also the anterior high resolution swept source OCT, which was launched in 2021. It's an amazing piece of technology that does great epithelium mapping, and also corneal maps are amazing, and it can also do all the curvature maps and the pachymetry profile maps, and it has an Ectasia score. In 2023, they further went ahead. MS39 has been around for a couple of years, which combines corneal topography and OCT based imaging into one, and it has a very high resolution swept source OCT. So I'll start by talking about a few of these devices. I started using the iTrace about 4 or 5 years back. It's an amazing piece of equipment. Basically, it's an aberrometer, so it has ray tracing wavefront aberrometry, and that is combined with corneal topography. So you can see that this is the topographer cup over here, and of course it also has ray tracing aberrometry combined in it. So it's an amazing device because what it can do is, while taking both the measurements, it can then try to identify and separate out the internal aberrations from the corneal aberrations. So what it will do is, it will take all the aberrations of the eye and also measure separately from the topographer the corneal aberrations, and then it can subtract the corneal aberrations from the total aberrations and tell you what are the internal aberrations. So that can tell you what is basically on the crystalline lens. So that helps you a lot in understanding where the origin of these aberrations are. So it helps you a lot with planning for refractive surgery, just like a normal topographer would, but it also gives you angle kappa and angle alpha, and it also gives you lenticular aberrations and the higher order aberrations, besides giving you the corneal aberrations. So the key features, as I told you, are corneal topography, wavefront aberrometry, and it has a ray tracing feature which can tracks the path of light rays through the eye to measure the total refractive power. So it will give you a eye trace refraction. So it gives you an aberrometer assisted refraction, which is again pretty accurate. The clinical applications could be in understanding all the aberrations of the eye for refractive surgery patients. It also measures visual function, and it can give you the PSF analysis, then the Snellen e-simulation analysis. So it tends to help you in diagnosing how the visual quality of the patient. And also you can study the changes in the accommodation up to 4 diopters, and it does a good visual acuity analysis. It has a corner screening software. It also helps understand the contrast sensitivity and helps in deciding which premium IOLs you can use. So it's a very nice device. It does have its limitations. If you have a dry eye, or if you have cornea is not very clear, or if it's in the presence of cataract, the aberrations will go haywire. So it does have some limitations, but by itself it can give you a lot of help in a refractive cataract practice. It also helps you with toric IOL planning, and it can give you toric check basically to see whether your toric is aligned correctly or not, and then it also suggests how much you can rotate to realign it. So just to show you an example, this was a patient who came to us, had 16.75 sphere in the right eye with a small cylinder, improving only to 618. In the fellow eye, which was the good eye, the power was just about -5 with a small cylinder improving to 6.6.
Excuse me.
So the right eye had been labeled as anisometropic amblyopia, and the left eye was obviously having just a regular myopic astigmatism. When we did the pentacam, we saw that the corneal thickness was fine, the curvature maps were fine. There were small suspicious areas on the Bellin's map in the right eye, and left eye seemed mostly clear. When we did the eye trace, which I just spoke about, the right eye showed significant aberrations on the internal aberrations. Basically, the total eye also had a lot of aberrations, but you can see that the cornea is very good. All the aberrations are on the crystalline lens. So the dysfunctional lens index is just about 1.6. And if you separate out the aberrations, so these are the total aberrations, and you'll see a lot of aberrations. These are the corneal aberrations, which you can see are negligible. There's almost, the cornea is very pristine, and all the aberrations are in the crystalline lens, even though it's a clear lens. This is a young patient. There is no cataract at all, and optically it looks absolutely clear, but the lens has all the aberrations. Now compare it to the fellow eye. Fellow eye looks much better with the one which is -5, and if you separate out the aberrations, there are almost no aberrations on the lens nor on the cornea. So it immediately tells you, while the left eye is very nice optically, the right eye has very poor optical function, mostly because the crystalline lens is having all the aberrations. The cornea seems good. So what should we do for this patient? Kumar, if you are hearing and watching out, what should we do for this patient, for the right eye and the left eye?
No, what was the...
So I'll quickly take you back. -16 in the right eye, -5 in the left.
The quality of vision could have been subnormal. He could have been amblyop in that eye.
Exactly,
also.
but look at the aberrations. These are the aberrations of the right eye.
Was it a Indian phakic IOL or?
No, there's no phakic IOL. This is just a refractive surgery candidate.
Oh, okay.
Yeah. So one eye has almost no aberrations. The right eye has so many internal aberrations and none on the cornea. The other eye has no aberrations at all. So obviously the left eye, I'm going to go ahead and do a smile or something for that. What should we do for the right eye? Should we go ahead put an ICL? There's enough AC depth.
Yes.
Or looking at these maps, you want to offer something else?
See, what is the index?
The DLI? Okay. So the DLI is 1.6.
So theoretically, you're supposed to treat the lens.
Optically, the lens is absolutely clear. There's no cataract.
So then something's wrong with the DLI.
Yeah. So it's basically an aberrated crystalline lens.
Yes.
Too many aberrations, right? So
it could be. It was no lenticonus or nothing at all like that.
No lenticonus, nothing. Sorry. Right. So that's what I was coming to. This becomes a very useful tool to decide whether it's a lens. Now, suppose the same patient had no aberrations on the lens. Then we knew it was amblyopia and nothing else. But here it's so clear that the aberrations are all from the crystalline lens. So we went ahead with a dysfunctional lens exchange.
Oh, very good.
And following the procedure, patient's DLI obviously improved to 9.58. Patient also got a plano outcome with a 6.9 kind of a vision in that eye. And fellow eye, of course, we went through with a smile, and you can see the DLI in the smile eye is actually worse than the pseudophakic eye. Yes. So patient very happy with both eyes outcomes, and that was one representative case. We also use a lot on the anterior, which, as I said, is an anterior segment swept source OCT, which also doubles up as a biometer, and it has excellent depth of penetration. It can give you scans from the cornea to the posterior capsule in one picture, along with the limbus and beyond. And it is, I will not go into the detailed features, but it does a great job of not only a deep, capture, but also a wide capture of almost 16 millimeters and a depth of almost something like 12 millimeters. So it gives you everything in one go. And it does a great job with the biometry. It also has ray tracing, and so it can do ray tracing biometry measurements as well. So corneal disease, it gives you the cornea module, which helps diagnose epithelium maps, also the maps which are basically from the stromal thickness maps and the ectasia scoring software. The glaucoma module, which gives you the angle studies and measurements, which are pretty good now. The refractive surgery module, which gives you all the cornea curvature maps as well. And as you compare it to the pentacam, you can see that it stands out as giving much more information. But pentacam has been around for long years, and we still trust the pentacam for many of the softwares that it comes with. But the OCTs, all the anterior segment OCTs are coming of age, and they are gradually probably the future. Even pentacam has launched an OCT-based, refractive measurement module. So I won't go into the detail, but if you look at the corneal maps from the anterior on the right side and from the pentacam, you will see that they stand out as pretty much comparable. And so we do use the anterior now for much of our refractive surgery evaluations. This is the fellow eye, and again you'll see that they come out quite comparable. Epithelium maps are done in a 7 to 8 millimeter zone, and they come out good as well because they can be used to subtract for the for giving you the stromal thickness maps as well. So these are the epithelium thickness maps for one of the patients that I can see over here. This is a score analyzer, and the ectasia score can be seen here on a index over here, and if it's in the range of maximum up to a +1, 1.5, it's good. Beyond that, it starts going into the red. I think another application for the anterior for us has been phakic lens planning. I'll finish with this because I've run out of time, so I'll just finish with this. The anterior and the other the OCTs like the MS39 and the Cassia, they can all be used for very good phakic lens vault planning and sizing, because they are able to give you very good measurements of the scleral spur to scleral spur or to the angle, as well as also the crystalline lens rise and the lens vault and the AC depth very nicely. So these measurements can all be used for various of the new formulas like the lasso techniques, where you can do very good ICL sizing planning and vault predictions. So we have been using the Anterion for this purpose as well, and it has come out pretty good. So we've gone on from white to white and AC depth measurements for ICL measurements, ICL sizing to ICL sizing on the Anterion, and these are all the measurements that I mentioned that you can do on that. And this is how it looks. So your yellow line is signifying the scleral spur to scleral spur, angle to angle, and these are the vaults, the lens crystalline lens rise and the lens vault. So I think this was one of the KIMS software, which KIMS nomogram, which can be used for sizing, and we've been using this for our purposes and found that this works out much better than the manufacturer's nomograms. So we use this in addition to that. So with that, I think I'll stop because there are so many other speakers, and I'll invite Dr. Chitra to invite.
Please join us back on the ties. Don't be a busy man. Will you take a question?
So, Gaurav, to you, you have the eye trace for many years and this dysfunctional lens index. If you would have done clear lens extraction or something like this, how much does it protect you in legality? Because that's the only machine that gives you this. So will it protect you in legality, or it doesn't protect you in legality?
Also, sir, the outcome itself can vary significantly based on how well the tracy refraction. It's a ray tracing refraction, and a lot of aberrations can arise if the refraction itself is not on point. And a high myopic eye like that, for us to be 100% sure that the refraction was perfect, and whatever we are seeing is only because of aberrations, is very difficult to say, because like you said, we don't have comparative devices to measure it. Like we can measure white to white ACD with so many devices, and we know that one overestimates, one underestimates. So yes, I do believe that at least I won't go only by DLI as a single measure as far as decision making goes. And obviously that patient is amblyopic and doesn't have the same quality of vision as they would in this eye. And I don't think it would have been wrong even if we did a phakic IOL in that eye instead of doing a clear lens extraction in a high myope.
Yeah, that's for other reasons, more than the high myope which is coming in the way, because of the view of the myope, the retinal condition.
Absolutely.
It's not working.
So maybe we have time for one more question, since Gaurav sir is also there in the hall.
Yes.
Sir, if you can take one question just on AIOS2025 epithelial thickness. I mean, we are seeing very often that there's a lot of changes in the epithelial thickness map, especially after refractive surgery, and serially we do these maps, we see continued change. So while we do attribute a lot of regression to the epithelial thickness itself, how does it change your decision making as far as the treatment outcomes are concerned, or treatment planning is concerned?
Right. So post-op, we monitor epithelium thickness maps for most of our refractive surgery patients, and we found a big difference in many of them. For example, between SMILE and SMILE Extra, there's a clear difference between epithelium remodeling. In PRKs, between trans-PRK and PRK, there's a difference in how the epithelium thickness, evolves over the next 3 to 6 months. And there will always be outliers. You will notice some of your PRK patients who are not doing well, and they keep coming back even 3 to 4 weeks or 6 weeks after surgery, and you wonder why they are not seeing well. And if you just do the epithelium maps, you'll realize some of them are lagging in that epithelium healing. They'll still be having like a 40 micron epithelium, which is not regular. There will be some astigmatism, and you'll see that astigmatism on the MS39 epithelium maps, which is clearly showing that astigmatism because of that, line of fusion where the epithelium has closed. So I think today, more than the post-operative patients, more than the pentacam or something, I actually see the epithelium maps much more. And you see them over 6 months or a year, and that evolution happens, and then eventually some of them will get epithelial hyperplasia, and then you can quickly see that why there was a regression. Others will have delayed epithelium healing responses. So I think it's a learning experience, and I'm learning over the last few years that I'm doing these epithelium monitorings.
Wonderful, sir. And yeah, Rudra's ready.
Gaurav, all the epithelium maps that we are seeing is central 6 millimeter. Am I right?
So the thing is, Anterion gives only about 6 to 7 millimeters, but I also use the OptoView for more than 10 years. That gives me 9 mm maps. Frankly, for example, like hyperopic ablations or large optical zone laser correction treatments, we see the maps much better on a 9 millimeter. The MS39 gives you 9 millimeter maps. Anterion is lagging in that, and I think even the Anterion's epithelium maps resolution is not, it's kind of has too many artifacts. But even that old OptoView with the 9 mm gives you a lot of information.
Again, one small challenge is that just like we spoke about the DLI, the epithelial thickness mapping and the pattern and the landmarks, how it identifies, is a little different from each of these devices. The OCT-based devices versus the ones which also combine Scheimpflug. I think what we get in Anterion versus what we get with the OptoView is the epithelial thickness is not as...
The thickness is off by 4 microns for every patient. So, when you're doing a planning for transepithelial, the OptoView will tell you to ablate 55 microns, and Anterion will be telling you 50 or 51, so then you don't